Hello everybody, my name is Tanner Parrett, and it is August 6th of 2020. This is going to be my case connections for Unit 2 of the University of New England's Medical Biochemistry class. So the first case I selected was case 1, and it goes, a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be the best to distinguish between urea cycle disorder and a disorder in beta oxidation? Blood glucose, urinary acid, serum fatty acids, or plasma glutamine. A full blood workup was ordered for this female, and the data is presented below. The data is the initial blood ammonia level was elevated to 314 per deciliter, and the normal range is 17 to 80, and it rapidly rose to 600, so that is much higher than normal. The urine uric acid level was markedly elevated at 473 creatine, when the normal level is 0 to 3, so that is also very high. The plasma citrulline level was normal at 10, when the normal is 12 to 55. So that's a little below normal, but in this patient where uric acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. After observing all the diagnostic tests, the test of plasma glutamine would help me best distinguish between deficiencies in beta oxidation versus deficiencies in the urea cycle. In the case of the urea cycle defect, there would be an increase in plasma glutamine as it helps the transport of ammonia through the urea cycle. N-acetylglutamate is required as an allosteric activator of a key regulatory enzyme in the urea cycle, carbamyl phosphate synthase 1. In beta oxidation, glutamine levels would remain constant as it is a non-essential amino acid that is not required for this process. A plasma glucose test would not be administered to compare the two processes, because it will tell us about gluconeogenesis and glycogenolysis. If the patient has signs or symptoms of diabetes, this would be a more appropriate test. A urinary acid test would be appropriate for testing the levels of uric acid from purine degradation. This would give us no information regarding beta oxidation, as it does not test levels of intermediates or products from this process. Finally, a serum fatty acid test would not be appropriate to administer, because it would not give us any information about the urea cycle, just lipolysis and beta oxidation. Using the blood urine data, ornithine transcarbamyl transferase is likely to be deficient in this scenario. An increase in ammonia tells us it must be a deficiency in the urea cycle enzyme opposed to a deficiency in beta oxidation enzymes. An elevated uric acid and slightly normal or lower than normal citrulline makes me conclude a deficiency in ornithine transcarboyl transferase. Arginine, another intermediate in the urea cycle, would also be reduced in this scenario. After further investigation, the symptoms of lethargy, hypothermia, and apnea would all be present in an individual with reduced levels of this enzyme. The enzyme would be least effective. The enzyme that would be least affected would be carbamoyl phosphate synthase 1, as it is directly upstream of the affected reaction. The next case I chose was case 4, and it reads, a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase severely based on his physical exam and laboratory findings. He is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from the individual are listed below, or side in this case. And they are, the patient has plasma urate of 10.5 when it should be less than 7, and a urinary uric acid of 215 milligrams per 24 hours when it should be 413 plus or minus 78. So the plasma urate is slightly elevated, but the urinary uric acid is very decreased. What is the best explanation for this presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. The choices are overproduction of purines, decreased salvage of purines, or decreased urinary excretion of uric acid. Second question is, after further discussion with the patient, he tells you that he recently switched from a diet soda to regular soda because he read that the fake sugar in diet soda was bad for him. He tells you he drinks 4 to 5 liters of soda a day. And then, what is the potential impact of this dietary modification on the presentation of gout? My answer is, after examining the data presented in this case, I conclude that an overproduction of purines would not be the best explanation for the presentation of the patient's gout. However, the patient is consuming excess of high fructose corn syrup through soda, which would increase the amount of purines in his body. The patient would not have a decreased salvage of purines based on the increased urinary uric acid compared to a normal patient. As compared to a normal patient's uric acid of 413 plus or minus 78 milligrams per 24 hours, the patient's rate of 215 milligrams per 24 hours is much lower than normal. This is because the patient has a decreased urinary excretion of uric acid, causing uric acid to build up and leading to gout. In the body, fructose is broken down to ribose 5-phosphate, which is then converted to purine. This purine is then degraded into uric acid, and the increased uric acid then builds up to cause gout. The symptoms of gout include stiffness, pain, swelling in the joints, knees, ankles, feet, and in this case, the big toe. Thank you, and have a great day.